We cannot imagine a world without women. Fit women leads to a fit family. However, as the woman ages, health priorities differ. The aging process, menopause, and physical inactivity all bring ailments to women's health but are not considered to much extent. There exists a bias. This Women's Day, let's break the bias. Let health not be the barrier to being a happy woman. Let's learn to make women fit to take part. Health is a priority to all. Break the bias. This Women's Day, I'm going to talk about women health from perspective of a cardiopulmonary physiotherapist. Cardiovascular disease is the leading cause of death in women, and the majority of these deaths are attributable to coronary heart disease. Cardiovascular disease was responsible for 35% of total deaths in women in 2019. There is, unfortunately, more bad news. Once a woman develops coronary artery disease, her prognosis is worse than that of a man. Possible reasons for the poor prognosis of women include their increased age and more advanced disease at presentation and increased comorbidity. In patients with established coronary heart diseases, women were more likely to have hypertension and diabetes and to have higher cholesterol levels than men. A study reported that women have been underrepresented in or excluded from cardiovascular clinical trials, which has reduced the ability to measure the safety and efficacy of therapies for women. The potential for identifying sex-specific differences in important outcomes, and the development of sex-specific strategies. The predictive value of coronary risk factors is better for women than men and is particularly strong in young women. Identification of risk factors is not only helpful in assessing chest pain in women, but is very important in preventing death from coronary heart disease in women. Identification and treatment of cardiac risk factors are therefore essential in women's health. Smoking is the leading preventable cause of CHD in women, with more than 50% of myocardial infarctions in middle-aged women occurring among women who smoke. Smoking may be more hazardous to a woman's health than to a man's because it lowers the age at first myocardial infarction more for a woman than for a man. Smoking is therefore another risk factor that appears to negate the age advantage in women. Elevated total cholesterol and low density lipoproteins levels are coronary risk factors in both men and women. A low level of high density lipoprotein cholesterol, however, is a better predictor than elevated low density lipoprotein cholesterol in women, but not in men. In addition, elevated triglyceride levels appear to be an important risk factor for CHD in older women. The study of women's health across the nation investigated women during the menopause transition and documented a sharp increase in total cholesterol and low-density lipoprotein cholesterol concentrations within a one-year period around the first menstrual period, which was associated with a high risk of carotid plaque at later follow-up. Diabetes appears to be a more powerful risk factor for women than men. Women without diabetes generally present 10 years later than men with CHD. The presence of diabetes negates this age advantage in women. It is associated with a 3 to 7-fold increase in CHD risk in women compared with a 2 to 3-fold increase in men. The increased risk may be attributable to the worst effects of diabetes on lipids and blood pressure in women. Increased blood pressures are another important risk factor for development of CHD in women. A study published in 2020 suggests sex-related differences in presentation and cause of hypertension with a more rapid increase of progressive blood pressure elevation in women compared with men, beginning as young as 30 to 40 years. Hypertension is also an important risk factor for stroke in women. Due to gender differences, conditions specific to women can increase cardiovascular disease risk, like obstetrics and gynecological history, including gestational hypertension, gestational diabetes, preterm delivery, premature menopause, polycystic ovary syndrome. Another cardiac risk factor that is certainly unique to women is the relative estrogen deficiency of postmenopausal state. A natural protective effect of estrogen in premenopausal women is postulated, and to account for the age advantage for women before the onset of cardiovascular disease. Estrogen deficiency is associated with increase in total and LDL cholesterol, decreases in HDL cholesterol, and adverse effects on coagulation parameters and endothelial function. Few of the studies have reported early hazards of hormone replacement therapy as well. It is postulated that the early hazards of hormone replacement therapy may be related to procoagulant or pro-inflammatory effects, but this is not clear. The hormone replacement therapy have reported high incidence of thromboembolic and gallbladder disease. A study has reported that in women with a prior myocardial infarction or atherosclerotic disease, use of hormone replacement therapy for less than 1 year was associated with an increased risk of recurrent coronary events. Increasing duration of use was associated with a trend of decreasing this risk. There are other factors which contribute to cardiovascular disease in women but are under-recognized. Depression is an independent and long-term risk factor for both obstructive and non-obstructive coronary artery disease in women. Low levels of education also contribute to increased cardiovascular risk associated with socioeconomic deprivation in women. These factors are associated with poor health literacy and can influence unhealthy behaviors such as smoking, poor diet, and low amounts of physical activity. When cardiac risk factors or CHD is identified in women, primary or secondary prevention strategies should be implemented. Exercise has beneficial effects on cardiovascular morbidity and mortality rates and several cardiac risk factors. It should therefore be an integral part of any risk factor modification program. Several population-based studies show that increment levels of regular physical activity are inversely proportional to long-term cardiovascular mortality rates when controlled for the presence of other risk factors in both men and women. Specifically in older women, a study of more than 32,000 postmenopausal women found a graded inverse relationship between leisure time physical activity and cardiovascular mortality over 7 years of follow-up. Physical activity has been associated with favorable effects on obesity, body composition, insulin sensitivity, and blood pressure, along with modest effects on lipoprotein profiles. In addition, regular exercise also seems to encourage beneficial lifestyle changes such as smoking cessation and stress reduction. Exercise training appears to be an important component for weight loss and for the development of a more favorable body composition and fat distribution with regard to CHD risk. The better results occur when diet modification is added to an exercise program. Physically active women have a more favorable weight to hip ratio than do sedentary individuals. The beneficial effects of exercise on glucose metabolism include increased sensitivity to insulin, decreased production of glucose by the liver, and the reduction of obesity. Observational data have also suggested an inverse relationship between physical activity and blood pressure in women. The combination of exercise and weight management have the greatest impact on blood pressure and supports the multidisciplinary approach to risk factor reduction. Psychosocial factors, including depression, anger, and stress, have all been shown to be related to increased mortality and morbidity rates. It has also been shown that patients with depression and other confounding psychosocial stressors are less likely to adhere to programs of risk reduction and intervention, thus perhaps also negatively affecting mortality and morbidity. It has been shown that intervention with stress management techniques and exercise training helps to improve mental health in these patients. Beneficial effects of exercise on blood lipids have been suggested in studies of both men and women, but few investigations of the effect of exercise on lipid and lipoprotein proteins have been performed in women. A study reported that HDL cholesterol increases with physical activity in women. The effect of exercise on lipoprotein profiles are certainly modest, and few studies have conflicting results because estrogen is associated with increases in HDL and triglyceride levels and a decrease in LDL cholesterol, and hence the variable results may arise. The long-term success of any prevention program is directly related to patient compliance. For women with CHD, enrollment in cardiac rehabilitation program is much less as compared to men. The reason for this gender difference in participation rates are discussed in few studies. The studies report that potential barrier to women's participation in cardiac rehabilitation are that more often they have less social support, or more likely they have a dependent spouse at home, or sometimes they have non-cardiac morbidity such as arthritis and low back pain. Other patient-related factors associated with non-compliance included physical inactive leisure time, blue-collar employment, and sedentary occupation. There are clinical recommendations for cardiovascular disease prevention in women, and women should adhere to it. More policies should be considered. More education strategies should be adopted to educate and promote health literacy in women so that coronary heart diseases or cardiovascular diseases can be prevented in women. Guidelines recommend consistent encouragement of women not to smoke and to avoid environmental tobacco. Encourage women to accumulate a minimum of 30 minutes of moderate intensity physical activity like brisk walking on most and preferably all days of the week. consistent encouragement on overall healthy eating pattern that includes intake of variety of fruits, vegetables, grains, low fat or non-fat dairy products, fish, legumes, and sources of proteins, low in saturated fat, limited saturated fat intake to less than 10% of calories, limit cholesterol intake up to less than 300 milligrams per day, and limit intake of trans fatty acids. Women with a recent coronary syndrome or coronary intervention or a new onset or chronic angina should participate in a comprehensive risk reduction regimens such as cardiac rehabilitation or a guided home or community-based programs. Prevention strategies should include consistently encouragement for weight maintenance or reduction through an appropriate balance of physical activity, calorie intake, and formal behavioral programs when indicated to maintain or achieve a BMI between 18.5 and 24.9 kgs per meter square and a waist circumference less than 35 inches. Women with cardiovascular disease should be evaluated for depression and referred and treated when indicated. As an adjunct to diet, omega-3 fatty acid supplementations may be considered in high-risk women. Also, as an adjunct to diet, folic acid supplementation may be considered in high-risk women, except after revascularization procedures if a higher than normal levels of homocysteine has been detected. Women should be encouraged to maintain an optimal blood pressure of less than 120 by 80 millimeters of mercury through lifestyle approaches. Optimal levels of lipids and lipoproteins in women should be encouraged through lifestyle approaches. In high-risk women or when LDL-C is elevated, saturated fat intake should be reduced to less than 7% of calorie. Cholesterol should be reduced to less than 200 milligrams per day, and trans fatty acids intake should be reduced. Lifestyle and pharmacotherapy should be used to achieve near normal HbA1c less than 7% in women with diabetes. Cardiopulmonary physiotherapy has a great role in prevention and rehabilitation of cardiovascular diseases. There is a need for enhancing awareness of cardiovascular disease in women. Education is a crucial resource in raising awareness about cardiovascular disease prevention, risk factor reduction, and intervention, both in women as well as the cardiopulmonary physiotherapists. There's a need to target well-established, sex-specific, under-recognized and under-recognized risk factors. Prevention is better than cure. This is the need of the hour to take action against cardiovascular diseases and promote health in women. Thank you.